Hello everybody, welcome to a new episode of the Dissenter. I'm your host Ricardo Lopes and today I'm here with Dr. Rebecca Roache. She is senior lecturer in philosophy at Royal Holloway, University of London. She teaches practical ethics, logic, philosophy of mind, philosophy of psychiatry, philosophy of language and early modern philosophy. She has also been Research Fellow at the Oxford Centre for Neuroethics and Programme Manager of the Oxford Loebel Lectures and Research Programme at the University of Oxford. Before that, she was James Martin Research Fellow at the Future of Humanity Institute. Since 2013, Dr. Roache has been an associate editor of the Journal of Medical Ethics, and since 2007 she has also been a contributor to Oxford's Practical Ethics, Ethics in the News blog. So Dr. Roache, thank you a lot for taking the time to come on the show.
Thanks for having me.
Oh, it's my pleasure. Okay, so today I've decided to ask you to talk about philosophy of psychiatry because it's really not a common theme, let's say, I guess, even in philosophy. So I would first like to ask you, I guess that when people think about psychiatry, they associate it with medicine and with science, and perhaps they think that it's something that is part of science and that probably should not be discussed at the philosophical level, let's say. So, what is the first thing that people should know about philosophy of psychiatry, and why should we reflect on how psychiatry is done?
Well, it's a hugely fertile area for philosophers. So I think it was Jonathan Glover who, sort of a few decades ago, pointed to this area as kind of unexplored by philosophers, and something that, sort of by looking at people with mental illnesses, problems of cognition, and so on, that we could learn an awful lot about how we think in general. There's sort of all sorts of avenues for exploration. So it can teach us about the way we think through looking at pathologies of thought, if you like. There are sort of ethical issues involved. So psychiatry is one of the few areas of medicine where people tend to be occasionally treated without their consent. There's issues around sort of what it counts to be capable of consent and to be autonomous, capable of making informed decisions about one's treatment and so on. But really the way I've come at it is through a kind of philosophy of science angle. So my interest is mainly in what is the conceptual structure of psychiatry. So it's unusual in that it's a branch of medicine, and in that respect you think it sort of fits firmly into sort of medical framework. Mm-hmm. But on the other hand, it's sort of informed by this psychoanalytic tradition, which is not particularly scientific in various respects. And it's still today, it sort of draws on both of those aspects. So mental illnesses will sometimes be treated and viewed by psychiatrists as if they are, well, kind of the same sort of thing as somatic illnesses. So that there's some sense in which being schizophrenic is like having a broken leg, that both of those can be thought of as disease states in some way. But on the other hand, there is this approach which tackles sort of mental illness in a more in a way of sort of tackling the sort of rational processes behind it. So when somebody goes for psychoanalysis, for example, they're not going to be treated in many ways as a patient is in medicine. So they're not going to be subjected to tests and so on. It's all about sort of how their thoughts and beliefs and feelings relate to each other. And whereas the sort of first way of looking at mental illness I've described, views the mind in a similar way to the body, as something that can be explored by science. The psychoanalytic tradition in some ways treats the brain as a black box. That's something you sometimes hear said, that it's not interested in the sort of biological workings of the brain. It's interested in the rational connections between different thoughts and emotions. And what we have today is this kind of mishmash of approaches which sometimes don't relate to each other in very helpful ways. So there's these sort of questions about, if you want to tackle depression, for example, if you want to cure somebody of depression, you can take a biological approach. You can give them pills, or you can take what we might call a sort of psychological interpersonal approach, is that you sort of might talk to them and attempt to resolve things that way. And so there's this question about how all these different approaches mesh together, and what is the sort of underlying structure of psychiatry? What's the sort of underlying view of mental illness and patients that pull all this together? So that sort of motivates my main interests in this area.
Okay, so I guess that are a lot of tricky questions there, and perhaps the first one would be, so if we have all of these different approaches, what is the best way to really classify something that gets expressed behaviorally, let's say in terms of the behavior of the patient or something like that, to classify a set of behaviors as a mental illness or a mental condition, or something that is simply wrong with the person?
Well, that's a good question. Sometimes it is about behavior. So, we diagnose people with mental illnesses often primarily on the basis of their behavior. So unlike sort of a lot of somatic illnesses, you can't just do a blood test or a scan on somebody and diagnose them with a mental illness that way. So psychiatrists have to rely on behavioral signals and sort of talking to the patient, finding out about them that way. But often the way we think about certain mental illnesses involves not just behavior but other things as well. So if you take something like schizophrenia, that might have sort of big behavioral characteristics. So somebody who is schizophrenic might occasionally, when they're psychotic, behave in an erratic way. But that's not all that's going on. The other things that will be going on will be to do with the patient's own experience. So you would expect them maybe to have sort of certain irrational beliefs. And perhaps it might be the case that their brains differ in some way from people who are not schizophrenic. There's sometimes progress that seems to be made in this direction, where with certain mental illnesses, it looks like possibly one day we'll get to a position where mental illnesses can be seen to correlate with certain brain states. But that's not always the case. So there is this question about how we bring these things together. What are the significant, important factors for diagnosing and treating mental illness? Are we trying to change behaviour, or is it the patient's subjective states that should be the target of treatment, or should it be some sort of biological pathology? And generally, I think sort of in most cases, you find psychiatric illness is characterized in terms of the patient's distress. So that's the important thing. If a patient has a certain set of symptoms and they're not causing any distress, then in most cases that's kind of seen as okay and not something that a psychiatrist should take an interest in. There are a few exceptions. But then if we're talking about the main thing being the patient's distress, then that raises questions for, well, how does that affect the effort to by some psychiatrists to characterize mental illness in terms of biological pathology? I mean, what would happen, for example, if we found that a certain set of brain states corresponded to depression, and yet it turned out you sort of ended up with, it's conceptually possible, you would think, that you could get a patient with those brain states who claims not to be experiencing depression. I mean, if you got into a situation like that, what then would be the deciding factor for saying that a patient does have a certain condition. So there are these sort of quite difficult sort of philosophy of science type problems about there being sort of different levels of explanation of why patients experiencing certain things or behaving in a certain way. You can look at their behavior, their experiences as reported by them, or whatever it is that that comes up in a brain scan. You would hope that there's some sort of conceptual framework that can pull all this together and show how these things fit together, but we don't quite have that yet.
Mm-hmm. Yes, I think it's very complicated because on the one hand, at least part of the diagnosis depends on the reporting of the patient. That is, the patient tells the doctor, the psychiatrist or the psychologist in that case, how he or she behaves, what he or she feels, what he or she thinks, what happened in his or her life, and things like that. And people's reports of primarily about the causes of their behavior, they are not really that reliable, because even people's memories don't work as we think, and people forget a lot of things, and people pay more attention to certain things than others and things like that. But on the other hand, I guess that if someone says that she feels bad with the way she behaves or something like that, that we should pay attention to that. But I guess that another point would be also that perhaps sometimes people behave in certain ways that other people don't deem to be good for them, or that have bad consequences, and the person itself doesn't think that, even with the bad consequences that she gets, that is something, that there's something wrong with her or them. But so it is very complicated here, because we have to evaluate what people think about their own behavior, the consequences of that behavior for them, what other people think of the consequences of their behavior, and all of these things, right? And sometimes there might be a conflict even between what people think is right or wrong with themselves and what specialists think of that, right?
Yeah, I think so. And there's just a disconnect with the rest of medicine. So whether you have cancer or a broken leg or a cold is something that how you feel about that is kind of irrelevant. If you're diagnosed, there's one. Whether you can be said to have a certain somatic disease or disorder is one issue, and how you feel about it is another one. Whereas with psychiatry, it can be more central. I think that distress takes a more central role in whether and how people are diagnosed.
Mm-hmm. Right. And when I was talking about the part of how people classify the behaviors or consequences of the behaviors of other people as good or bad or appropriate or inappropriate, it always has a moralistic side to it, right? Because it also depends, at least to a certain extent, to what a certain society at a certain point in history deems to be appropriate or inappropriate behavior, or moral or immoral, and things like that, right?
Absolutely. So that's a really interesting point, I think. So if you look up what the sort of official diagnostic criteria are for delusions, for example, sort of whether somebody can be said to have delusions. One thing that's explicitly stated in the DSM, so the official guide to diagnosing mental illnesses, is that a delusion has to be a belief that is not endorsed by one's culture. So if you believe that you're a bird, for example, and you live somewhere like the UK, then, you know, if you sort of, that might count as a delusion. But if you are part of, if you live in a culture where that's kind of part of a sort of, you know, a belief associated with religion, say that's sort of dominant in your culture, then that's not going to count as delusion. And this is something that that Richard Dawkins has picked up on. No, not writing about psychiatry specifically, but he has this book called The God Delusion, where he's claiming that the belief in God is a form of delusion. And, you know, you can sort of maybe see what he's getting at, but a belief in God sort of doesn't count as a delusion because it is it's prohibited by the guidelines for diagnosis. That it's a belief that's common in a lot of cultures, and so it's not going to count as a delusion. So that's an example where sort of how we conceive as a pathological state is going to be influenced by cultural considerations. And there's sort of more general examples of that. So personality disorders are sort of sets of traits that cause problems for people's interaction with others. And when you sort of read through what's involved, they are just, it's hard to conceive of what the problem is unless you are open to the view that, you know, we have these norms and expectations about the way that we relate to others, and there's certain things that cause problems for our ways of relating to others. And in certain cases that can constitute a personality disorder. But again, that's sort of heavily influenced by this sort of prior set of beliefs about what healthy interpersonal relationships involve.
Mm-hmm. Right. Okay, so I think that this would be a good point to introduce a question that comes from one of my patrons, because since you referred religion and Richard Dawkins, I guess that religion also has the side of the natural basis to it, that is the cognitive basis to it, and how, I mean, where it comes from is not really a pathology or something wrong with people, is simply the result of certain biases that we have evolved and how people deal with the world and think about it. So I would like to introduce now the question coming from my patron Francis Ford, and he says, I would love to hear Dr. Rebecca Roache's thoughts on adaptationist accounts of mental disorder, which argue that conditions such as depression are selected for adaptations in past environments. One such account is the analytical rumination hypothesis. I guess that what he's trying to ask here is that, so there are people like evolutionary psychiatrists nowadays that deal with certain mental conditions. In this case, he gives the example of depression as perhaps behaviors that in past environments were really adapted to deal with those environments, but perhaps nowadays in more modern industrialized societies and the way we live, they are no longer adapted, or perhaps they are no longer useful for people to deal with the conditions they live in, or something like that. And perhaps we could go back here to how we classify behaviors as mental diseases or mental conditions or not, because I guess that with this perspective in mind, then we wouldn't really classify something as depression, at least as abnormal, let's say.
Yeah, so this is a really interesting set of issues, I think. So I think that there's two main things I might say about this. The first is that, there are aspects of ourselves, you know, some people have argued there are aspects of the way we are that we have evolved because they are advantageous, but which might be sort of out of date or just not really advantageous anymore. So, you know, sort of basically you might think, well, we've evolved so that we can, you know, that the whole point of the way we've evolved is to enable us to survive long enough to pass on our genes to be able to procreate. But, you know, as it happens, especially in today's world where people are sort of living longer and longer, we want to live and be healthy long beyond the age at which we can procreate. So sort of there's a lot of resources going into old age medicine, sort of helping people live longer and stay fitter. So that's just an example really of how this isn't a problem sort of peculiar to psychiatry. The fact that we have evolved to be certain sorts of beings, and there may be some good reasons for that, but the cultures that we find ourselves in now may have different requirements, and our priorities might differ. So there is going to be that sort of aspect of medicine. It's always sort of trying to, I guess, sort of hurry up evolution, or sort of make amends for the fact that the evolution is kind of out of date in a way, or we might think of it in that way. So that's one point, that this is more of a general problem. Another point kind of relates back to what the purpose of psychiatry is, and the purpose of medicine more generally. So let's say, let's grant that sort of depression has there are good adaptive reasons for why we have depression, and just sort of ignore the fact that or the possibility that those adaptive reasons might not apply anymore. So say it's sort of good that we have depressed people in our society. Let's just imagine that's the case. And then there's a question of sort of, well, what should we do about that? It could be that it's the case that it's good for society to have a few depressed people around, but that doesn't entail that it's a good thing, all things considered. When we treat people for in medicine or in psychiatry more specifically, usually the purpose is to improve things for that patient. So it's thought to be bad to be depressed because it's unpleasant for the person who is depressed. When patients are treated for depression, we're not sort of thinking more generally about the consequences for society as a whole. We're not sort of thinking about, sort of what if, what if we sort of alleviate this person's symptoms? How might that impact on society more widely? We sometimes take those sorts of things into consideration, but I think usually the emphasis is on the distress of the patient. So that just highlights, I guess, a question of priority. What is it that we want to achieve from treating medical conditions generally? Is it to improve the lot of the person who has that condition, the patient, or is it to improve things more generally? And I think sort of usually we prioritize the welfare of the person, the patient. That's not always the case. So an obvious example of where that's not the case is vaccination, where it's often the case that if you get vaccinated against a disease where sort of most people in your society are already vaccinated, you're probably not going to gain much personally by that. But it's thought to be important to get vaccinated in order to achieve a herd immunity. So the priority there is is keeping society in general free from this disease. It's not that sort of by going and getting vaccinated for measles, say, you're likely to be sort of gaining something personally. So that's an example of where we might prioritise, primarily society over the welfare of the patient. That's kind of quite an easy example because as somebody who goes and gets a vaccination, you're not really suffering a great deal as a result of that. So perhaps it's something we don't view as too sinister. But there are controversial examples from psychiatry where we might worry about this. So this is not so much to do with the sort of evolutionary point, but to do with the point of sort of whose welfare are we prioritising? Is it the patient themselves, or is it the welfare of society in general? So if somebody is, there's some cases where patients might get treated involuntarily, sort of against their will, if they're thought to be a danger to others. So if you get somebody who is psychotic, for example, and resistant to being treated, they might be sort of held down and sedated because it's thought to be important for everybody else's safety. So the worry is that they might harm somebody else or harm themselves. And these cases tend to be much more controversial than the vaccination case. So in the vaccination case, you don't really you don't have to suffer very much from getting vaccinated. You might get a few side effects, and you know there's the mild discomfort of having a needle stuck into your skin. But treatment of psychotic patients without their consent is much more controversial, I think. There is this sort of question about sort of what is it to, I mean, what are the relevant factors in deciding when this is okay? It might be very distressing for them to be treated, so it's something that you tend to take more seriously. But you know, this issue is around generally in medicine. You know, there's a sort of, even if we sort of aren't always aware of it, there is always a sort of background question, sort of what are we trying to achieve through a given treatment.
Mm-hmm. Yes, and when we pathologize something, I mean, it's really very difficult to separate, sometimes at least, some of it from the ethics and morality behind it, because I've just remembered what people tried to do, or even did effectively, a few decades ago with homosexuals, where they tried to convert them forcefully to heterosexuality in this case. And I mean, nowadays we know that that's not really a mental disease or a mental pathology. It's just really a normal variation in terms of sexual orientation. And so we also have to take that into account, right? That sometimes what people at a certain point in history or in a certain society deem to be a mental pathology that is to be treated or eradicated, I mean, perhaps there's more morality into it than people want to admit, right?
Yeah, no, I certainly think so. I mean, a contemporary, something similar to that, or sort of a difficult problem that's around at the moment, is the issue of gender reassignment surgery, especially for children, for minors. So, you know, there's some people that think that if you are a young person, say sort of below the age of 16, say, and you sincerely believe that your body doesn't match with your self-conception, your beliefs about what gender you are, that someone in that situation should be allowed to have gender reassignment surgery. And there's other people that are sort of wary of this. And we're sort of torn here on there's sort of, on the one hand, there is this issue of autonomy, sort of who knows better than the person. You would hope that the person sort of telling you that that their body is all wrong relative to their gender should be listened to. Just because there's a precedent set by sort of all sorts of other cases where patients' views about what they need is listened to. So, well, that's a good thing to do in these cases. But on the other hand, you know, there's some data to show that people who have this surgery regret it later on. It's permanent, and there is. We perhaps want to leave room for the possibility that sometimes people might be mistaken about this. And this is a very difficult set of issues, which sort of raises these questions about sort of what are the relevant factors in allowing somebody to make, or sort of recognizing a person as capable of making competent decisions about themselves. Now, how much should we rely on the autonomy of an individual, or what we perceive as their autonomy, and how kind of paternalistic should we be? You know, so you might think in some cases there are people who are just wrong about what sort of illnesses they have. So, you know, somebody might think they have cancer. You know, let's take a very simple example. Somebody might think they have cancer, and a scan shows that they don't. So, we want to make room for the possibility that people just might be wrong about their conditions, and factor that in. But when you're talking about states of being that aren't going to show up on a scan, it becomes a lot more difficult. Yeah, and psychiatry is just replete with those sorts of conditions, and just states. You know, it's not just about pathology, but the sorts of states of being that aren't going to show up on a scan. And then there's a question about sort of how much how much can we rely on a patient's self-reports?
Mm-hmm. Yes, you were just saying there that there's also the question of how much we should patronize people, because we might think that the things they want to do, they might regret them later, and in some cases it's irreversible. So perhaps I would like to put on the table now the example of someone who wants to commit suicide. So let's say that the person has already gone through a lot, long years of depression or something like that, and she has already thought a lot about it, and she decides that the best thing for her is just to kill herself. So, and she doesn't have access to euthanasia in the health system, and so she decides to kill herself in some way or another. So in that case, that the person arrives at that decision, even though what she wants to do is absolutely irreversible, to what extent should we respect that person's decision? Because when we talk about this, and suicide is a very contentious issue because it involves directly death, of course, people usually say that, oh, but we have to save that person anyway, because perhaps most of the time, if that person has lived a little longer, then she would have overcome her condition and her bad feelings and bad emotions and things like that, and then later on she would have regretted if she decided to kill herself or something like that. So what would you say about that?
I mean, these cases are really interesting, and there are of course, real life cases like this that arise, especially in so Belgium. It has this law where euthanasia is available not just for people suffering from terminal cancer and other somatic illnesses, but also in cases of mental distress. And it tends to be a lot more controversial in to allow somebody to die or to help them kill themselves in a case where they are suffering from terminal cancer, say, is less controversial than making euthanasia available to somebody with incurable depression who's just kind of given up. And it's interesting to think why that is. There's a sense in which we take the threat from somatic illness more seriously than the threat from mental illness. And one thing I think is to be aware of the possibility that difference in attitudes might stem partly from a failure to take mental illness in general very seriously. So this sort of old-fashioned view that's sort of often rightly criticised, where the sort of depressed person is told to pull themselves together, or their distress isn't taken seriously. Depression is not a real illness. These sorts of attitudes. So I think we have to be careful that our thoughts about when it's okay, when it's sort of ethically permissible to help a person commit suicide, are influenced by sort of beliefs about how serious their state is. And so that's one thing. And I think another thing is that something that's kind of under-recognised is that euthanasia, even in the case of terminal somatic illnesses, is actually sort of underpinned by mental distress. So if you might say, well, if somebody has a terminal illness, terminal cancer, say, and they have, as is sometimes sadly the case, they've received all the treatment they can get. It's not doing any good. They're sort of too weak and beaten down by the idea of receiving any more treatment, and so they ask to be allowed to die. We tend to be sympathetic towards those cases, I think, but the significant thing is the distress they're going through. So it's not the fact that they are terminally ill that leads us to think that euthanasia is appropriate. I mean, in one sense, that doesn't even make sense. You might think, well, why does the fact that this person is likely to die very prematurely or very soon itself constitute a reason for helping them to die? I think, well, how does that follow? Well, I think, when you tend to look at the cases in which it happens, it's people who have sort of given up. They don't want to fight anymore. They don't want to fight their illness anymore. And those are the cases when we tend to be sort of sympathetic to, or sort of think that euthanasia might be appropriate. But in that sort of case, it's the mental distress that is doing the work. It's the sense of sort of having given up. And in that sense, it's not unlike the sorts of cases that you mentioned when you introduced this topic, that the idea of sort of somebody who's very depressed. I mean, with something like depression, there is perhaps this thought that you can get better, which is, I think, just a sort of inability to take seriously the idea that some mental distress is very difficult to, or impossible to cure. But I think that's also that's what's going on in the cases of incurable somatic illness as well. It's not really the fact that somebody's going to die that's doing the work, that's making sort of euthanasia seem like a viable option. It's how they feel about it. It's the fact that it's distressed them, it's beaten them down, it's weakened them. So I think actually these two cases are pretty similar.
Mm-hmm. Yes, that's all very interesting, and I guess that perhaps when people think about mental care or medical care, they think about people saving other people, preventing their deaths, preventing their suffering and things like that. And I mean, it's very difficult for people to imagine helping someone by terminating their lives. But let's say that, for example, someone who suffered from depression their entire life is at their deathbed, and she's, for example, 80 years old, and she says, "Oh, I lived 80 years and I haven't experienced a single moment or day of joy or happiness, so my life wasn't really worth living." I mean, in that case, shouldn't we think that perhaps it would have been better to help that person end their life much sooner? Because, I mean, as she is reporting, she really went through 80 long years of suffering, at least mental suffering, right?
Yeah, well, so I think we should take that sort of thought seriously. There's maybe sort of two precautionary comments I'd make. The first is that, I've been talking about incurable depression, with this assumption that we're talking about a case of, something that is actually incurable. But we should also be aware of the fact that, just by having depression makes people sort of give up and might think sort of life is pointless. And so there is a concern that the desire to die might be a symptom of the depression rather than a sort of sincere, autonomous wish. And then there are questions about, well, how do we tell the difference, and can we draw a clean line between those? But that's something to be aware of, I think. And there's also the point that if there is some objective fact about whether or not somebody's life is worth living or not, you sort of talk about somebody who's got to 80 and hasn't experienced a single moment of pleasure, then we might think, well, if we're tempted to conclude from that the right thing to do then is to help this person die, then what do her wishes about it matter? If her life is genuinely not worth living, then why not just help her to die, or euthanize her, whether she likes it or not? And that's a pretty sinister thought, I think, which I think reveals how important the patient's perspective is. It's not just a matter of objectively, or if that's even possible, sort of something approaching an objective judgment about sort of whether somebody's life is worth living or not. Although that is important. We want to be sure that it's a last resort, that we can't help the person in question recover and enjoy life. But at the same time, we want to take the patient's wishes seriously. So it might be that we encounter somebody who just had a terrible life, seems never to experience happiness, but is quite determined to carry on, who doesn't want to die. And you sometimes do hear about these people. I mean, it would seem sort of terrible in that sort of case to euthanize them against their will, I think. So you have this sort of tricky juggling act. On the one hand, you want there to be some sort of objective fact of the matter, or at least a fact that doesn't merely depend on patient self-reports, which can be, you want to leave room for the possibility that they're mistaken, about whether that person's life is really worth living. But on the other hand, the patient's wishes seem essential here. We don't want to be euthanizing people without their consent.
Mm-hmm. Okay, so now let's move on to another topic, because I also wanted to discuss with you, because for the last several years, since particularly the advent of gene editing technologies like CRISPR-Cas9 and others, we've been talking a lot also in philosophy and ethics about issues regarding human enhancement. So in the field of psychiatry and in terms of mental conditions and mental experiences and psychology in general even, how should we think about dealing with enhancing certain psychological traits of people?
Yeah, so some of the most well-known enhancement technology, smart drugs, are drugs excuse me, that originate in psychiatry. So people sometimes use Ritalin as a concentration enhancement, say, which is a medication that's given to people with ADHD. And this is to be expected, I think. I think that when you're talking about psychiatric disorders, it makes sense to view these things as existing on a spectrum. So if you are, I mean, we all feel down from time to time, right? We sort of have, even people who have no sort of reason to go and see a doctor about their condition might feel depressed, melancholy on the odd day, and that's just part of normal functioning. We have days when we feel unhappy, or sort of things happen to us to make us feel unhappy. So that's sort of one end of the spectrum where you sort of have that's psychological distress is just part of normal life. But on the other end of the spectrum, you have sort of too much of it. So sort of feeling depressed every day, and regardless of what happens to you, strikes us as pathological. And in between, you have this sort of spectrum where it's sort of not clear where you should draw the line between pathology and non-pathology. And the same, I mentioned ADHD. You have these cases that we might be sort of inclined to view as pathological, where somebody sort of just can't concentrate for more than a few seconds, and that sort of severely impacts their life. But on the other hand, we all have moments when we find it difficult to concentrate, and sort of lots of us wish we could concentrate better. And then there is this question again about sort of where we should draw the line between pathology and non-pathology. So enhancement, as it's commonly understood, involves sort of taking the resources that you might usually use to treat pathological conditions, so to treat depression or ADHD or some other mental pathology. Now I'm sort of confining my discussion here to sort of psychiatry. And using those resources, using those drugs or techniques, tools, etc., to improve normal functioning in somebody who is not who is mentally healthy, if any of us are. So that's what it is. But there is an issue about, for sort of partly because of reasons I've already mentioned, there's sort of this issue about sort of, well, how do we define pathology in psychiatry, given there's there's nothing kind of equivalent to an X-ray showing a broken leg, or a blood test that reveals the presence of some bacteria or virus. You get in somatic medicine, you can think, yes, this person is uncontroversially and unambiguously ill. You just don't get that in psychiatry. So there is this question about sort of where you draw the line between health and illness. And some sort of advocates of enhancement are in favour of just removing that line between health and illness, or at least arguing that it's not morally significant. So if you take something like Ritalin, it's sort of used sometimes as a smart drug, currently sort of officially it's available only to people who are suffering from a psychiatric condition like ADHD. But, you know, given that it can improve functioning in people who are not ill, in inverted commas, why not just make it freely available to everyone, provided that it's sort of provided that it's safe and is distributed fairly, and so on. So yeah, I think you know, there is this sort of wealth of opportunity in the tools that are used to treat psychiatric conditions. That stems partly from the fact that psychiatric conditions exist on a spectrum, where something that improves the lot of somebody who is thought to be in a pathological state sometimes also improves life for people who are healthy.
Mm-hmm. Okay, so I guess that there's two issues here. On the one hand, the fact that we classify some things as pathologies and others not, and perhaps enhancement in certain cases is not really enhancement but simply therapy, right? And on the other hand, it is also who gets access to those sorts of enhancement, because if all people get access to them, perhaps we don't really have a problem there, right?
It depends what it is, I think. So if everybody had access to I'm trying to think of a good example, but you know, let's say we all want to improve our concentration. I'm not sure that's necessarily the case, but just sort of imagine we all want to improve our concentration, and there's some drug that can enable us to do that safely. Then it would be a good thing. You know, we might think if everybody had access to that. You know, there's no. If it's safe, there's no bad reason to do it. We can all kind of just get on with what we want to be doing without sort of procrastinating or dawdling and so on. We can be a lot more efficient. But I think not all enhancements are like that. I mean, if you imagine the possibility of a drug that improves our competitiveness, like something that makes us sort of more driven and compete more aggressively. I mean, if you took that drug and nobody else did, then that might be an advantage to you. You know, you sort of might get that job you were after, or you sort of could perform better than your peers against whom you're assessed. But if everybody took that, it's not necessarily going to be a good thing. I mean, if we're all just kind of trying to claw our way over each other, then sort of nobody is actually better off. And that sort of drug would be what's sometimes called a positional good. So I think that this term originates from an economist, Fred Hirsch, where he describes sort of some goods as being advantageous to some people, provided that other people don't have them. So a sort of clear example might be being taller. That if you want to be taller so that you can sort of see better in crowds, then taking some drug or having some procedure so that you can be taller might benefit you. But if everybody else has it, then it's just nobody sees better, and yet we've all sort of invested resources in this procedure that actually doesn't get us anywhere. So I think we have to be careful at what we're aiming at. We should avoid or we should be careful about plugging resources into helping people achieve goods that are positional. But if the end is to achieve something that is not positional, so that something good like happiness, where if everybody has it, it's a good thing. You know, sort of nobody loses out. Then that's the sort of thing that's a sort of clearer, good candidate for enhancement, I think.
Mm-hmm. Interesting. Okay, so the last topic I would like to cover here today is the application of psychiatry and neuroscience applied to psychiatry in criminal cases. Because, I mean, there has been a lot of discussion about in what cases should we use medical or psychiatric information in cases where people are accused of committing certain crimes, and then perhaps not considering them responsible for those crimes for a reason or another. So how should we deal with those questions?
Well, you mentioned sort of moral responsibility, and I think so. Moral responsibility is something that sort of philosophers are still arguing about, sort of, and probably won't ever stop arguing about. This is the set of issues around sort of whether we have free will, whether we can ever really be held morally responsible for anything we do. I mean, some people think that we can't, but the law is a whole arena where it's premised on the idea that we are morally responsible. So there's no point even in sort of having a system of punishment. If nobody is morally responsible, then it's inappropriate to punish anybody, right? At least for retributive reasons. So the law is just starts from the assumption that we're morally responsible, unless in a particular case there's some reason to believe that somebody was not responsible for what they did. So if it can be shown that somebody was coerced or blackmailed or not of sound mind, so sort of delirious, or in some cases a crime of passion, sort of overwhelmed by emotion, then sometimes the law will sort of be more lenient on people like that. But I think sort of what you're talking about is sort of recent moves to prove people are not responsible for what they do. We get things like sort of brain scans being produced in court to show that somebody's brain was abnormal, and I think that is a really worrying step. It's worrying partly because we don't know what underpins. Well, from the point of view of being a lawyer, right, we don't know what sort of underpins moral responsibility. Philosophers disagree about it. So what you've got in these criminal cases is a sort of a tinkering with the assumption that we are all morally responsible, but you might be able to produce evidence that somebody's not. Now, a brain scan, it is thought by some psychiatrists and neuroscientists that we're making progress towards showing that there are actual brain differences between, say, psychopaths, or sort of violent people, and mentally healthy people. So you could imagine a case of a violent psychopath in court for some violent crime, and a brain scan being produced where the lawyer says, look, his brain's different from most people's, so he's not morally responsible. Now there's a whole set of problems here. The first is sort of, well, what can we take that to show? What can we take sort of mere difference in brain states to show? I mean, you might think in one sense, well, yes, if assuming that our behaviour arises in part from what goes on in our brains, then you would expect the brain states of somebody who's very violent to differ in sort of certain respects from somebody who's not. But that doesn't yet show anything about moral responsibility. To show that, you would have to show something further. Not only is this person's brain, not only does this person's brain look like the brain of a violent person, but that the violence was in some sense not this person's fault, that they're sort of not morally responsible for it. And that's the step that's worrying, I think. You sometimes get this discussion in psychiatry about sort of whether certain people, so whether somebody with whether a psychopath, say, is mad or bad, so whether they are morally responsible for what they do, or whether they are just ill. I mean, it might not be that there's a clean line here. It could be that that both are possible. There needs to be a discussion about sort of moral responsibility in the case of people with mental illnesses. But this can't be done I don't think this can be done keeping in place the assumption that people who are mentally healthy are morally responsible. I mean, what you've got when you sort of have two, if you compare the brain of a healthy person with the brain of a violent person, that just doesn't show you anything about moral responsibility. That discussion is just not something that takes place at the level of brain scans. So I think this is a concerning step in law.
Mm-hmm. Yes, and when we discuss these matters, it almost always go to the discussion about if free will exists or not. But I mean, if free will were to not exist, then perhaps we shouldn't put anyone in jail because he or she has done something bad. I mean, perhaps on the other hand, it's also a question of people nowadays being more aware that perhaps we shouldn't treat people in certain ways, and perhaps most people that commit at least violent crimes, they come from difficult conditions in life, and perhaps they should be maybe rehabilitated instead of simply put into a jail or something like that. So there's also these parallel questions here, right? And perhaps when people sometimes try to make the case that no one is morally responsible for their actions, because it's sometimes, at least, it's because they don't like the way people are treated when they are accused of certain crimes. Correct?
Yeah. So I think these questions are relevant if what we're doing when we punish people is retributive. So we're punishing people. The reason for punishing people is primarily because they've done wrong and they deserve to be punished, in some sense. I mean, if we're not interested in retribution, if we're interested in deterrence, then, or just keeping dangerous people isolated so they can't do any harm. If this is what we're interested in, then these questions kind of don't matter. If it looks like society is going to be a better place by putting some person in prison, then if that's all you're interested in, sort of these sort of consequentialist approaches to punishment, then fine. But what we're talking about here is retribution and the cases where people are thought to deserve punishment. And I think this is sort of really a really difficult set of issues. So what is involved in somebody deserving punishment? Because, as you say, sort of the more we learn about people and why they behave in the way that they do, the more we sort of end up with this. Well, I suppose the closer we get to a causal explanation of why they're behaving the way we do, the less appropriate retribution is. And you see this, I think, in the sort of assumptions that lie behind this sort of what we were just talking about, introducing brain scans in court to show that that criminals are not responsible for what they do. It sometimes happens that as soon as you sort of introduce the possibility of pathology, or the idea that somebody's ill, we are then sort of willing to consider the possibility that it's not their fault. There's this sort of whole debate about the moral responsibility of the psychopath, where sort of it seems a mainstream view among philosophers who write about this sort of thing, that psychopaths aren't morally responsible for what they do. It might still be a good idea to lock them up. If they're violent, you might just think that's necessary for public safety. But there's a sense in which they don't deserve that, where sort of deserve relates to moral responsibility. And I think it's this issue is just going to become. It's just going to go on and on, because the more we find out about why people behave the way they do, the greater the possibility is for these kind of mitigating explanations that undermine moral responsibility.
Mm-hmm. Okay, so Dr. Roach, just before we go, I would like to ask you to please give us a short teaser on your upcoming book on swearing, that I know that you're writing it now, so could you tell us a little bit about it?
Yeah, so I'm interested in what swearing is. So it's a type of offensive language, but it's unlike other forms of offensive language. So it's not like sort of slurs, sort of racist, homophobic language people are familiar with. It's not like blasphemy. It's not like merely insulting people. So all of these forms of speaking are ways of being offensive, but swearing seems to be in a category of its own. So I'm interested in characterising what swearing is, and also considering what sort of norms surround it. So we are all, I think, familiar with the idea that we shouldn't swear, at least in certain circumstances. But it looks like that sense of shouldn't doesn't relate to morality most of the time. It's not the case that you shouldn't swear because it's harmful or because you are infringing somebody's rights. In most cases, it's a different sort of shouldn't. So I'm interested in unpacking that, and I understand swearing as a type of etiquette breach. So sort of, well, to summarise it very briefly, we shouldn't swear because it's impolite. But then there's all these sort of interesting issues about how we mitigate swearing. So often it's the case that if a TV show wants to broadcast somebody swearing, but they don't want to get in trouble for it, they will censor it. So you'll get a swear word bleeped out, or asterisks will be used if it's in print. But often it's enough information is left there for it to be very clear what swear word was said. So I'm interested in how this all works. How it is that we manage to swear without causing offence, and what that says about what swearing is, and how we do it.
Mm-hmm.
And finally,
okay. Sorry, go ahead. Yeah.
And finally, I'm sort of interested, like, as a sort of positive way of finishing the book. My last chapter is on the value of causing offence. So I think there's some people who are unable to cause offence through swearing, and that's sort of bad for them. They lose out in some way. So certain disabled people, that speaks with the age of technology, maybe a sort of machine to enable them to speak, and just maybe sort of people with sort of unconventional voices. So somebody with a very high voice, for example, might have trouble causing offence through swearing. And the fact that we sort of think that it's bad for them, I think, reveals something sort of not often recognised about the capacity to cause offence. That there is something good about it. It's valuable in some way.
Mm-hmm. Okay, very interesting. So, and what are some of the best online places if people want to know a little bit more about your work?
Well, I've got a website. You can look at that if you Google my name. That will come up. I'm on Twitter as well, although most of my Twitter feed is kind of nonsense rather than about my philosophy. But you can say hi.
Okay. So, Dr. Roache, it was really a pleasure to have you on the show. It was a very interesting conversation. And maybe, perhaps when your new book is out, we could have another one. I don't know.
That would be lovely. Thanks so much for having me.
Hi guys, thank you a lot for watching this interview until the end. I'm recording a new ending just to let you know a couple of new things, but I mean, I've started this channel in February 2018 and I've been putting out a lot of interviews with academics and intellectuals. So to keep the channel sustainable, I would really like to ask you to please visit my Patreon page and to consider making a pledge there. And if you don't like Patreon or prefer other platforms, you can also go to PayPal and subscribe from $1 to $20. I have all of those options in the description box of the video, and you can also make a one-time donation on PayPal. And also you can go to Subscribestar and pledge any amount there, so you have all of those options to support the channel. And so before I go, I would like to give a huge thank you to my patrons: Karen Litske, Anne Blanchett, Perelga Larsen, Lau Guerrero, Chantel Gelinas, Jim Frank, Francis Ford, Hans Frederick Sunda, Brian Rivera, and I'm very proud of this, my first producer, Izar Webb. Thank you for all.